think I need to speak into this, that if you want to go back to this lecture, that you can look at the images again. I show you lots of nice images, even though I'm sure you are familiar with lots of nice images. I think cardiac imaging is beautiful, and that's, I think, what attracted me to cardiac imaging. So when I finished medical school, started applying for jobs, I was interested in everything really, and then it was really by chance that I got a job offer that involved research in this field, magnetic resonance imaging of the heart, which didn't tell me anything. I googled it a little bit, didn't find very much, and I thought that's probably a good start, that there's not that much published, and then that's how I got involved, and I absolutely love it. And it's really, since 1998 when I started, it's changed massively. So the images that you now see are so much better than what we acquired at the time in 1998, and so much faster. So the change, for example, was what I'll show you is LV function, left ventricular function of the heart. We could acquire, fairly nice images, about 2 minutes for each slice through the heart. So to cover the entire heart, to be able to calculate volumes of the heart and pumping function of the heart took about 15 minutes, just that process. Now that's about 3 breath holds now, 4 breath holds. So we can acquire so much more information and at much, much better quality. So the field has moved very, very fast, but I think there are still plenty that can be done. And so there's no clinicians here. Normally I do talk to clinicians. I've given talks to non-clinicians before, so I do generally try and avoid medical jargon too much. But if there's anything that you don't understand, I'm quite happy for you to interrupt. And I hope that that doesn't do any harm to the recordings. I'd rather like it be interactive, but you can also keep your questions and we'll have a discussion afterwards, and I can go back to slides. So actually, let me just double check. I think I actually have got the wrong presentation up there. I apologize. Just double check again. I've given another presentation very recently, and I think this is the one that I've pulled up. Apologies. Just give me 1 minute. I think that one would be too technical. We shouldn't have gone for that long coffee break. I should have checked I've got the right slide up there. I apologize. So so I wanted to start. So my bias is that I do cardiac imaging of the heart, but particularly with one methodology which is called cardiac magnetic resonance imaging. There are lots of different ones, and my talk is very biased to magnetic resonance imaging because that's what I do day in, day out. But I will mention the others. And so in 1905 or 80, just sort of around 1900, Röntgen actually invented X-ray, and that was really the first way of us being able to determine the size of the heart. It was a very crude way. So you looked for this diameter here and put that in a ratio to the lung diameter, and that was sort of a rough measurement of how big your heart was. So if you had an enlarged heart, then obviously that ratio would change because the heart size increases. It then took a long time, until 1929, until X-ray was used for screening purposes, and a German guy called Werner Forssmann, that's quite an interesting story, he later won the Nobel Prize. A surgeon in Bad Kreuznach, which is very close to where I come from, he had this idea of putting a catheter into his right heart, and obviously nobody had done that before, and he basically walked into the X-ray department in front of the screen and basically cut up his vein here, put a urinary catheter into his vein and pushed it into the right heart, and basically proved the principle that you actually can do a right heart catheterization, which is now something that we do day in, day out, and that led then to the left heart catheterization, which is done all the time for people with heart attacks and chest pain. Now, he actually then got sacked by his boss because it was such a crazy idea to do, but he later won the Nobel Prize. So that was sort of another way of looking at the heart in more detail. And then it took, again, quite some time until echocardiography emerged, which is now really the bedside test in cardiology, is used all the time. And certainly when I talk about cardiac MR, I'm never proposing that echo should be, you know, abolished and never used again. I do think we've got major advantages over echo in certain circumstances, but echo is the bedside test, and that was invented in 1954 really. And that's made major improvements also since. Invasive catheterization, by that I mean more looking in the left side of the heart where the coronary arteries are, that are often narrowed if you've got coronary artery disease, and when you've got heart attacks, one of these arteries blocks off. To image those, you actually need to go into the high pressure system, the arteries, rather than the veins for the right heart catheter, which Forssmann did. And that allows you also to look at the pumping function of the heart in quite detail, but it comes with radiation. That was in 1964. And then 1965, shortly after, another radiation technique, nuclear scintigraphy, was invented and described, which basically allows you to look at the pumping function again of the heart, and it allows you to also look at the blood supply to the heart muscle. But the problem there is that you're using radioactive tracers, and the radiation dose is not negligible. Then coronary CT angiography, I'll show you some images at the end of this, this lecture, is basically arrived in 1983, but again it's made major improvements since, and I'm sure I can convince you with those images. And cardiac MR, then advanced echocardiography, sort of in the 1990s till fairly recently, major improvements. Now we can do three-dimensional echocardiography. We can do feature tracking, speckle tracking, which is looking at strain and strain rate analysis within the heart muscle, using some sophisticated post-processing tools. There's contrast echocardiography, which gives you better contrast and allows you to get more precise measurements of the left ventricular function. And you can even look at the blood supply to the heart muscle with contrast. So it's made major improvements, this bedside test. And cardiac MR is really what I'm working on. You'll see loads of these slides. It's very versatile and doesn't use any radiation. That's the main advantage of it. So this is what a cardiac MR scanner looks like, very similar to cardiac CT. So it doesn't use radiation, but it's still a very dangerous work environment, and for patients if you don't follow strict safety rules, because it's extremely magnetic. 1.5 Tesla, 3 Tesla is what we're using, and I'm sure that tells you much more than it does to a clinician how strong a magnetic field that is. So if you walk in with anything magnetic, it becomes a projectile and can be really quite dangerous. But if you use it properly, it actually doesn't do any harm, and you get beautiful images. And particularly if you've got patients that you need to image every now and again for follow-up scan to look for change in cardiac function, then cardiac MR is certainly more attractive because it doesn't use radiation. So advantages: it doesn't use ionizing radiation, it doesn't use iodinated contrast agents, which have often a negative impact on kidney function, and quite a lot of allergic reactions that can occur to this type of contrast. So we're quite pleased that we're using different type of contrast. We can choose any anatomical plane we like with cardiac MR, so it's up to us to decide how we want to position it, which is a major advantage. With echo, for example, you're often stuck between two ribs, and then you've got lung interposition, and ultrasound doesn't go through air very well, so you then struggle to get good images, and you may have to accept an imaging plane that's not ideal. So with MR we can really freely choose that. Similarly with echo, often ultrasound, you don't get good images if somebody's very, has got a lot of fat layer there between your probe and the heart that you're interested in. With MR, as long as you can get them into the magnet, and you've seen that sort of thing, you get good images. So we're not limited by that. And the trend is that actually these bores become wider bore, which has some disadvantages, but so now we hardly ever have a problem getting somebody into the magnet. Even with claustrophobia, which is another potential problem, it's becoming less of a problem in these wider bore magnets. But the key really is that MRI allows us to look at lots of different things, and I'll go through some of these examples in a second. We can look at the anatomy, the structure of the heart and the big vessels. We can look at the function. We can look at tissue and characterize it. So we can look, is it scar tissue? Is it normal myocardium? Or is there anything else wrong? Is there fat? What type of tissue might it be in terms of when you're diagnosing tumors, masses in the heart? We can look at the blood supply, perfusion in the heart muscle. And we can even, and that's more of a research tool, we can look at the metabolism of the heart using some special thing that's called spectroscopy. And even there, there's a huge range of things you can look at. But this is really the only modality in a living heart, if you like, that you can measure the cardiac energy metabolism. And the big advantage is, because of the image quality, it's all quantifiable. So it's not just black. It's actually, even though the images are black and white or gray shades, it's very much about quantification and not this is an infarct or not. It's we can quantify how large that infarct is. It's a perfusion defect, yes or no, but actually we can quantify, and that is important for clinical decisions and for prognosis of the patient. Whole lot of range of different indications how we use it clinically. So when we started in 1998, when I started in 1998, it was hardly ever used for a clinical patient, really, to answer a question. Now it's standard practice. We run about 3,500 cardiac MR scans a year at Barts Health, and that number is going to go up, undoubtedly. So I'm not going to go into the detail there, that's more for clinicians, but it is actually a very clinically relevant tool. So cardiovascular structure and function with cardiac MR. We can measure dimensions and morphology, similar to what you saw on the X-ray, but we can do much more than that. We can do angiography, so we can look at the big vessels. We can look for the myocardial function or heart function. Phase contrast blood flow. Phase contrast is the technique we use, but we can basically quantify the blood flow, look at the direction of blood flow, see where's jets, forward jets, backwards flow. So particularly for valve function, that's important, that you can see whether you've got leaky valves or narrow valves that cause turbulent flow through them. We can look at the blood flow in the heart muscle, and we can characterize the tissue. Now you'll see some examples. So this is our box standard first 10-second scan, where we just know where is the lung, where is the heart. And unlike the chest X-ray that you've seen, we can actually see the structures much more clearly. Maybe not in this light, but you can sort of look at the lungs, you can see the heart, you can see the big vessels. So you can get a very good overview of, if you can dim maybe a little bit, I think that'll help throughout the lecture. So this is an angiogram of different structures. So on the right here, you've got an aortogram. So that's the big vessel coming out of the left heart, the aortic arch, and then you can see an interruption of this aortic arch, which is called a coarctation of the aorta. So that's one of the congenital heart diseases that you can have. And you can see that there's a lot of collateral vessels, so vessels that try to overcome that obstruction here to still be able to supply the blood for the legs and the rest of the body. And these are sitting between the your ribs, basically. They're called the intercostal arteries, and they're particularly prominent here because of that obstruction. So all of this is very, very important information you're gathering with basically a 30-second scan, giving some contrast agent, MRI contrast agent. This is another example of what's actually called a pulmonary vein angiogram. So you can see the heart circling around there, but in particular we see the left atrium, the left prechamber of the heart, and the pulmonary veins that bring in oxygenated blood from the lungs into the left atrium, then put it in the left ventricle, and it gets pumped out into the aorta to supply your body with oxygenated blood. So this is important for our electricians amongst the cardiologists, so the electrophysiologists who deal with heart rhythm problems. One of the most common heart rhythm problems, atrial fibrillation, gets more and more frequently treated not only with medications but also with an ablation, so some burning of the tissue in the left atrium here, because that's where the electrical activity stems from. And they often want to isolate electrically these pulmonary veins from the left atrium. And it's quite a variable structure, so a lot of people, and that's not, doesn't indicate that you are diseased or anything, that's quite normal. Sometimes you have a fifth pulmonary vein, or you have one common pulmonary vein, so there's quite a lot of variation. And when the electrophysiologists go around with their catheters, they don't often see how many primary veins you've got. So having that information before you actually start burning some of the tissue can be very helpful to have a successful procedure. So this is our bread and butter. This is what we call steady state free pulsation cines of the heart, because it's movie of the heart. And we have these long axis of the heart, which is called the 4th chamber, because you can see the 4 chambers of the heart, and the 2-chamber view of the heart, because you've got 2 chambers. If you then basically plan slices that we then call short axis slices through the heart, and usually you can acquire about 2 of those with each breath hold, you get these slices. So these are basically planned on these long axis slices, and you're covering the heart from the valve plane to the tip of the heart. And what you can then do is you can draw contours, and that literally is what we still do most of the time. We manually draw contours of this inner border of the heart and the outer border of the heart when the heart's relaxed and when the heart's contracted, which is called systole. And then you can basically calculate volumes of the heart and the mass of the heart, and you can calculate things like ejection fraction, which is a measure of the pumping function of the heart. So this is a very accurate, because of the good contrast, so very repeatable and reproducible, and a very accurate way of measuring left ventricular volumes, which is clinically extremely important to get that information. Phase contrast blood flow is basically this slightly odd-looking image which contains information on blood flow direction and velocity. And you can derive these curves if you draw a contour around here throughout these cardiac phases that you see in this movie. You can get these curves which tell you that this patient here has a lot of flow that occurs below this x-axis, which is leaky flow back through the valve. So you've got a patient here with quite significant aortic regurgitation. And you can see that the forward flow here is black, and at the end you can see that there's a white bit that's leaking in the other direction. So this is the black and this is the white bit, and you can quantify that. Myocardial perfusion is our bread and butter as well. Sort of 90% of our scans are patients who've got chest pain where you think maybe they've got narrowing of the coronary arteries, and we don't look at the arteries themselves, we look at the consequences downstream in the heart muscle, because the coronary arteries supply the heart muscle, and if you have a narrowing in one of them, you can usually compensate quite well at rest when you're lying flat in the scanner or doing nothing. But if you stress the heart with a medication, that the heart rate goes up and that there's stress on the heart, then you would unmask a problem in the blood supply. And that's usually when patients also get chest pain. And that's what we do. We stress the heart and we do the same image at rest. We give contrast as a bolus and acquire images every heartbeat. And that's what you see. The contrast arrives as bright, first in the right heart, then in the left heart, and then it comes through the aorta in the coronary arteries and supplies the heart muscle. You have to look at this a few times, and it's looped. So it comes into the right side of the heart, then goes through the lungs, comes back into the left side of the heart, and then it goes and puts this myocardium, the heart muscle becomes grey. And you can see here, this is a very homogeneous sort of becoming grey, hopefully that you can appreciate that, which is basically normal blood supply at rest. But when you stress this patient, then you can see that in this area here, you've got quite a large territory that remains quite dark, so it doesn't get as much contrast as quickly as all the other areas. So that's where a problem in the coronary artery is present and limits their blood supply during stress. So it's a very good way of identifying people who probably then need to go on to have one of their arteries treated with either a stent opened up and a stent put in, or needs a bypass operation to overcome that blockage. So tissue characterization is really something that's been around now, I think, for about 15 years, and has really changed and made cardiac MR a very, very important clinical diagnostic tool. And what it does is basically the contrast that we use is called gadolinium, and it's a gadolinium chelate because otherwise it would be toxic. But that basically you inject into an artery or into a vein, and it stays in the vessels, but it very quickly goes into this space around between cells called interstitial space. And in the heart muscle, this contrast arrives in the little blood vessels, and then it goes out of the blood vessels into this interstitial space. And if there is no problem, you've got no heart attack, there's no scar tissue in your heart muscle, then normally that happens very homogeneously, and then the contrast washes out, and your heart muscle looks very dark on certain types of images that we acquire, called late gadolinium images. But if you've got an area of a heart attack, for example, then in that area you have more of this space between the cells, this interstitial space is increased. And that's where the contrast hangs around for longer, doesn't get washed out as quickly, and then relatively to the normal heart muscle that doesn't have a heart attack, the washout of the contrast is much slower. So when you image 10 minutes after you've given contrast, and that's why it's called late gadolinium enhancement, you've got a concentration difference of the contrast between your heart attack site, where the concentration is higher, and the normal myocardium or the normal heart muscle. And that you can then use certain types of MRI sequences to really get that contrast properly imaged. And that's when you see here, this is a patient who had a heart attack in this area and has a very bright area. That's a heart attack. And you can quantify the size of it, put it in relation to the overall heart muscle mass. So we can determine heart attacks, we can determine the size, and that often informs you how people should be treated. It also, and you know, this was validated in animal work, and you can beautifully see how closely the late gadolinium enhancement matches the histology that you see of the heart attack. But what we've learned, initially we thought this is very specific to heart attacks, but then we realized, no, we see this more frequently, but the pattern looks different. So we saw it in heart muscle diseases other than caused by ischemia or lack of blood supply. There are genetic conditions like hypertrophic cardiomyopathy, dilated cardiomyopathy, etc. And we saw it quite frequently in these as well, but they have different patterns. So they may have a patch here and a patch there, or in the outer bit of the wall. A heart attack always involves the inner bit of the heart muscle. That's how the blood supply works. Can never be any differently. But if you see it in other funny patterns, you know there is some problem in the heart muscle, but it's not caused by a heart attack. And that can help you really diagnose patients much better. And what we're also learning now is that some of these patients, for example, hypertrophic cardiomyopathy, which is the most common cause of sudden cardiac death in young athletes, we can not only make a better diagnosis, but actually it also has a lot of information on how they're going to do and whether they're at increased risk of sudden cardiac death or whether they are actually at, quite an okay risk level. And that will influence your management of the patient. So there's a lot of information in these images. So these are more research tools at the moment. So there's lots of ways to look at the region. So I've shown you with these contour drawings of the short axis of the heart how we can get measures of the pumping function. That's what we call global cardiac function, but we can look at the regional function as well. And the heart is a fascinating organ, how it contracts. And I still struggle to entirely understand it, and lots of people still struggle. But it's fascinating. It contracts in all sorts of directions, and obviously it contracts and it relaxes. And it does that in very interesting ways. And the way we've started learning about this was using this tagging sequence, where you put basically a grid on your images that then changes with the contraction and relaxation of your heart. And you probably know this much better than I do. You kind of follow where this moves over time, and you can calculate things like strain and strain rate, and displacement, millimeter displacement, etc. You can also look at torsion, twisting motion of the heart. Very complex what the heart does. So this is the tagging, but there are other techniques that have advantages and disadvantages over one or each other. This one is up and coming more and more, because the major advantage of feature tracking, and I'll show you an image, is that you don't need to acquire new images. So this image is a different acquisition, so it takes you another breath hold to acquire, compared to what you've seen earlier, that we used for the pumping function quantification. To have that grid, it's a new application where actually with the acquisition you put that grid onto the image. Whereas this feature tracking uses the images that you've seen earlier. And this is another example of this tagging. So this is feature tracking. So we're using the images that you've seen earlier, and again we can in a similar fashion we can get these contraction patterns and relaxation patterns in all directions. So the heart's moving inwards, but it's also doing a circumferential movement, and it's got a longitudinal movement. So the valve plane moves towards the tip of the heart and moves back again. So all of this information we can quantify, and at the moment we quantify lots and we don't actually know what to do with this information. So that's where we are at the moment, to try and work out which diseases behave in a certain pattern using this, and how can this be clinically useful. So at the moment this is really a research tool. We can look at vessel stiffness, so I've talked about the heart a lot, but we can actually look at the aorta, which is a big vessel coming out of the left heart, which you can see a cross-section of here. And then, and this is the flow image again that you can see here. So you can see blood coming towards us here, bright, and you can get these flow curves. And from these curves, you can calculate something that's called pulse wave velocity, which is a measure of aortic stiffness. And you can measure the distensibility, which is essentially you're looking at the ability of the aorta to get bigger and larger again. So you're looking at the area change, and that area change then gets normalized to your blood pressure, pulse pressure, and that gives you a measure of aortic stiffness as well. That's called aortic distensibility. That's fairly straightforward to measure. Then this again, I've told you about the atrial fibrillation patients and that they often get now ablation procedures, so burning of the left atrium. This is an example where, again, this is research. We can again look at the damage that's been done to the left atrium, where the scars have been set, using this late gadolinium enhancement technique, but this time not looking at the heart muscle, this time looking at the atrial wall. And the challenge there is extremely thin wall, but you can see that this is for example, a patient who had an ablation around these pulmonary veins, and that's sort of reflected here in red. And this is where they basically put those burns, and that sort of reasonably well reflects what we can see. So this is CMR perfusion. Again, we can not only look at it visually, that we see whether there's a dark area which indicates a perfusion defect, we can quantify it. So with some post-processing tools, we can put these contours in, and then we can look at the contrast uptake in different areas. So this is the contrast in the left ventricular cavity, which is very bright here, so you can see lots of signal coming in here. And if you look in the heart muscle itself, there is signal increase, if there is a difference, like you can see here, that indicates that in that segment where you've got less of an upslope, that you've got a problem in the blood supply. So these are ways of quantifying your perfusion defect. This is my aorta, my big vessel, and we can get flow information not only in a two-dimensional way, we can now acquire this even in a three-dimensional or four-dimensional way. So 3 dimensions plus the time resolution. So this is very attractive because you can acquire this and then later on decide where you want to do your measurements. CT, I've got 2 or 3 slides, and that'll be then the end of my presentation. So the scanner looks very similar. The bore is a bit wider and a bit shorter, so claustrophobia is less of a problem, but it does use radiation. But there are other advantages of coronary cardiac CT. It's a very fast scan with high quality images and large data collected. It's less sensitive to patient movement compared to cardiac MR. It's cheaper than MRI. It's widely available. And there's no limitation from implanted medical devices, for example, pacemaker and brain clips, which is a contraindication to MRI. Again, a huge list of clinical applications, so it's extremely useful clinically. These are some of the images. So cardiac MR can look at the coronary arteries, those tiny little vessels supplying the heart muscle, but it's very challenging, and the image quality is not as good as cardiac CT. Cardiac CT's strength is really to look at calcifications in those coronary arteries, which you often see with atherosclerosis, so narrowing of the arteries, and you can look at the narrowing extent. So this is an example how you can quantify the calcification degree of the coronary arteries, and that's often expressed as something called Agatston score. These are images, these are angiograms of the coronary arteries, but they are non-invasive, unlike the cath lab where you have to put a cut into the artery to put a catheter up to the heart. These are just, you're lying in a CT scan and these images are acquired. So you can see the calcium here as very bright areas, and you can see some narrowing in these arteries. So different ways of displaying this. Then there's new software tools which Francesca, my colleague, is testing and using, where a plaque in the coronary artery is not always the same. So you can have lots of calcium, or sometimes you've got non-calcified plaque. And we believe that the non-calcified plaque is actually the one that causes more problems in terms of when it ruptures, that you can get a heart attack. So this is a tool that allows you to differentiate between the different types of plaque, calcified and non-calcified plaque. So we've been using that in some research that we've been doing. CT also doesn't want to sort of give up on perfusion, what MR is so good at looking at, because there are patients where we can't do a cardiac MR scan. If you've got a pacemaker, we can't do it. So CT is now also able to look at perfusion. But the main disadvantage is it comes with radiation. So this is my last slide. So we've got a few minutes, hopefully, for discussion afterwards. I just thought about, okay, what do I want out of you guys? Is there collaboration potential? Can I get you interested in anything? And I don't have a good solution. And I hope that by showing you some of the images, sort of the things that we can do, that maybe that triggers some ideas that you have that you can ask me to see whether that might be an interesting research project. But these are just some of the ideas I have. So more and more you can imagine that maybe fusing cardiac CT images and these cardiac MR images of perfusion defects might be informative to a clinician by seeing where the artery is narrow and then where the perfusion defect is, or where the heart attack is and how large it is in relation to the artery. So that could be interesting. There are ways of doing that, I believe, but I haven't actually actively used it. The post-processing I mentioned, a lot of what we do is still very manual, so you have to draw lots of contours, very time-consuming and frustrating. So there are companies working on automation, but it's still not perfect. So there's, from my point of view, clearly still lots of room for improvement. I'm interested, and I struggle to entirely understand and explain it. There are cardiac atlases out there. So one of my colleagues and friends in New Zealand has set up a big cardiac atlas where they basically have lots of cardiac MR images, and they have novel ways of annotating these images and analyzing these images, and then they link it up with clinical information, and you can do statistical meta-analysis on these images. He has done this in healthy people from population-based studies. We've got loads of patients, so I'd love to set something like this up in London and call it London Cardiovascular Atlas, but I think we need some engineering input because I don't think I entirely understand how this would be set up. New analysis tools might be, something that you could come up with looking at these images. Maybe there's new ways of looking at certain things. Obviously, there's sort of from the MRI side of things is, there are engineers and physicists working on developing new sequences that are maybe faster, overcome some of the artifacts we're getting, etc. So that's an area that needs constant development. And I guess really, I hope that this talk created a little bit of food for thought, and maybe you've got questions, ideas. And I think that's where I'd like to thank my colleagues I work with at the London Chest Hospital and at Barts. And I'd like to thank the organisers again for inviting me to give that talk, and I hope that this was of interest to you, and I'm happy to answer any questions.
So for the CT and MRI fusion, is it physically possible to acquire both at the same time, or would you have to take the...
They are acquired at different times. So, yeah, I guess you need some form of... I mean, I probably use completely incorrect terms. I think some rigid registration or something to kind of put them overlay each other. But there are different modalities and acquired at different times. So they're two different machines. Now, there are developments in providing PET-CT and CT MRI and PET MRI, so you sometimes now have these hybrid machines. They're still different machines, but just in one put together. But they're still different. I mean, they're acquired without moving the patient around, but they're still different imaging modalities. So they're never entirely acquired together.
The images you showed, are they all in grayscale when the clinician's actually using them? Or are you doing post-processing to get those?
The images are all, I mean, I guess they're raw data, which I don't know what they look like. It's all binary data, I guess. But then it comes out usually as a DICOM format. That's the sort of medical imaging format. And I guess we see them as grey images. We have ways and tools where you can click it into color, but that's not really useful. So we usually look in the grayscales.
So the image you showed with your blood flow, presumably that's taken quite a lot of post-processing then to do that?
It has, yes. One of my fellows, I think, spent a week doing that. I think it becomes faster, you know, when you know what you're doing. But at the beginning it was very, very time-consuming. And that's why it's not used clinically yet. So if you acquire 3D images with the time resolution, the major advantage is if you're then interested in looking at what the blood flow is like in the ascending part of the aorta as opposed to the one that's a bit further down the distal part of the aorta, you can do that afterwards. But the problem is it's still very time consuming to do that.
Does it actually help you to have the 3D image? Does that give you more information?
Well, that's again a question that's being discussed. So there's an entire workshop on this in Oxford in September, if you're interested, on 4D flow. And I think it brings together engineers, physicists, clinicians, and that's one of the questions I've been asked many times. Nobody's come up with a very clear clinical indication yet why it needs to be 4D. But I think if it's available and the post-processing becomes easy, then I'm sure that's the way forward, because it's always difficult when you've got images acquired and then you realize, oh, I forgot this image, and then you have to bring the patient back. So if you've got the whole lot of data, then you can always look at the images afterwards. But there must be a clinical application. But I think at the moment, because it's so tedious to analyze, nobody's really stated what that application would be.
When you do the manual annotation in the images, which precision do you need to be able to process the images in order to get some meaningful information from that?
It's a very good question. There's two different things, right? One is accuracy. How close are you to the real measurement? What the real value would be. So in terms of ejection fraction, for example, how close are we to the, what the ejection fraction actually is? And the other one is how precisely do we get the same number, which is probably even more important. The repeatability or reproducibility is probably more important, because when you bring a patient back, if you get a completely different number next time, then that's not very useful. So if you're systematically underestimating the ejection fraction, then that's not really a problem. You're defining your normal value according to that way of analyzing it. So I think the reproducibility is more important. But cardiac MR is pretty accurate. So when we do it manually, our coefficient of variation for reproducibility is about 5% in good centers, and I guess this is always, in real world, it's probably between 5 and 10%, which is acceptable. Echo is far worse. I mean, for some of the measures that echo does, the variability is about 30–40%, which is like basically you might as well just not report it or quantify it. Accuracy, cardiac MR again is very accurate for the LV volumes, because we are actually acquiring the whole heart and we are not relying on any geometric assumptions. Echo, until they've now developed 3D echo, actually is relying quite heavily on geometric assumptions. You usually acquire 2 long axis views of the heart, do your contours there, and then you assume your heart is an ellipse. And then you but if you've got a heart attack with, a very regional big bag called an aneurysm, you're almost certainly going to get very wrong numbers. But with MRI, given that we're covering the entire heart, that's not the problem. So I can't really give you a precise number. You need it to be 3%, close to the real value.
Is to understand if a software will do that automatically, how precise and accurate that software needs to be.
I think if I had a choice, then I think it should be more reproducible rather than accurate. If it's a systematic error, I think we could live with that. So if it's if you always come up 3% less than if we do it manually, what we believe to be the right number, I don't think that's a big problem. I'd rather know that, you know, if you analyze and you get the same number every single time, then I'm pretty convinced that that's the way we should analyze it. But generally in cardiology or in medicine, precision is, I think, the numbers that you are used to in terms of how precise it needs to be. I think we'd be delighted if we got anywhere near that.
I'm just curious about those images that you showed, measuring forward and backwards flow. You said it's a phase image.
Yeah.
It was in what sense phase? The one with valve. Valve.
It's called phase contrast because obviously we're measuring spins. So this is physics which you probably understand more than I do. So obviously protons spin around and you're sort of disturbing them and you're changing direction of them by using it's called a bipolar gradient. And then I guess you're changing the phase as well of that proton, and that's kind of why it's got that phase contrast in that word. So the sequence that measures flow in cardiac MR is called phase contrast sequence. That's where that term comes from. It's a phase shift, I think, so they're kind of spinning. And you're...
And they get transported by the blood flow, so you
Yeah.
see that. Okay, gets it. Got the rough idea, thanks.
And the greater that shift is, the faster the blood. And I guess it tells you also about direction.